a continuation of the adrenergic nervous system, which we have discussed in our previous class. Now, just a brief recap about what we have studied in our previous class. We did the adrenergic neurotransmission. We understood that there are three major endogenous catecholamines, that is your epinephrine, norepinephrine, and dopamine. And then we discussed about the neurotransmission, the adrenergic receptors, mainly two types, the alpha and the beta receptors. And we also studied about the pharmacological actions of norepinephrine, adrenaline, and also about isoprenaline. So then we started with the classification. So we have discussed that there are three types by which the adrenergic drugs are classified. One is based on the chemical structure. They are classified into catecholamines and non-catecholamines. Then, depending upon the type of the action, they are classified as direct acting drugs, indirect acting drugs, and also mixed action drugs. So, to understand the therapeutic classification, I told you knowing the pharmacological actions of the endogenous catecholamines on the receptors was very important. So, based on that, we discussed how the drugs could be used for their action on alpha receptors as vasoconstrictor agents. So, these could be used in hypotensive conditions. Then, because of their action on beta 1 receptors, which are present in the heart, they could be used as cardiac stimulants. And because of their selective action on the beta 2 receptors, which are present on the bronchial vasculature, bronchial or bronchioles. So, because of that, they are classified as bronchodilators, and acting on uterus, they are uterine relaxants. So, in addition, most of the drugs also have CNS action, so they could be used as CNS stimulants and appetite suppressants. So, this was the therapeutic classification. So, direct acting based on the receptor action. So, they are again selective and non selective, alpha or beta specific action, or a mixed action. Then we have the mixed acting drugs. I told you which act directly on the receptors or which also act on the norepinephrine transporter. Then is your indirect acting drugs, which are releasing agents, amphetamine, tyramine, ephedrine. Okay, so all of these are your indirectly acting drugs. So this was the therapeutic classification which I was talking about based on the pharmacological actions. Pressor agents are nothing but acting on the alpha receptors and bringing about vasoconstriction. Cardiac stimulant, beta 1 receptor action. Bronchodilators, beta 2 action. Uterine relaxants, beta 2 agonist action. Nasal decongestants. So, whenever you have had a cold or a running nose, when your nose is completely congested, you use certain sprays, isn't it? The main action is nasal decongestant action. And then you have the CNS stimulant action and also the appetite suppressants, which are called as anorectic agents. So, let's talk about the individual drugs and their efficacies. So, the major endogenous catecholamine, which is secreted by the adrenal medulla, is your adrenaline. Okay, I told you most of the neurons, most of the sympathomimetic neurons which are present in your body, they secrete norepinephrine. That's the most common neurotransmitter. Adrenaline is produced by the adrenal medulla in response to a flight or a fight response. So, this adrenaline, as you've already studied in the treatment of anaphylactic shock, you know that it's a life saving drug, isn't it? So, adrenaline is one drug which cannot be given orally. This is because it is acted upon the metabolizing enzymes monoamino oxidase and catechol O methyltransferase. So, because of that, it gets degenerated, and for this reason, it needs to be given parenterally. So, which parenteral routes can it be given? It could be given through the subcutaneous route or the intramuscular route or the intravenous route. But please remember, the concentration or the dilution of adrenaline varies with each of the different routes. For example, when you are giving adrenaline through the subcutaneous or the intramuscular route, you have to give adrenaline at a concentration of 1 is to 1000, zero point 0.3 to zero point 0.5 milligrams. So this is what you have to remember. Anaphylactic shock comes as a treatment of anaphylactic shock comes as a 5-mark question. Very important. Even in your practice also, you should know the dosage of adrenaline. So it is given preferably IM route, because you know what happens in shock. There is always peripheral vasoconstriction. This is your compensatory mechanism to increase the blood pressure, isn't it? So your capillaries, your vasculature is constricted. So what happens when you give it through the subcutaneous route? Absorption is not up to the mark. So for that reason, what do? You give adrenaline through the intramuscular route. IM route is the most preferred route. So during that time, you have to give it at the concentration or dilution of 1 is to 1000. Then, if at all you plan to give the drug IV, so IV we generally give it in case of severe congestive cardiac failure or tamponade, cardiac tamponade. In such conditions, you give it through the IV route. If at all you're giving through the IV route, you give intracardiac injections at that point of time also. And if you're giving through the IV route, it has to be at a at a very high dilution. So it is either 1 in 10,000 to 1 in 1 lakh infusion. If at all you tend to give 1 in 1,000 dilution of adrenaline through the IV route, the person is going to die because of tachyarrhythmias. So this is through the IV route. Inhalational route, this was used in bronchial asthma before the advent of your selective bronchodilators, but now with the availability of salbutamol, salmeterol, and the other long-acting beta-2 agonists, adrenaline is no more employed through the inhalational route, not preferred. Mainly, I mean, if at all we are using, it's in very young children who have severe bronchospasm. In that condition, it is still being used through the inhalational route. So during the inhalational route, the concentration is 1 to 100, that is 1% or 0.5%. Please remember these dilutions. They are very much essential for your Viva Voce examinations. The other type of use of adrenaline is its combination with a local anesthetic. I suppose you've all heard about lignocaine or lidocaine, isn't it? So, along with lignocaine or lidocaine, we usually combine adrenaline at a dilution of 1 is to 50,000 or 1 is to 2 lakh. So the main action, because of its vasoconstrictor action, it prevents the absorption of local anesthetic into the systemic circulation. So the duration of action of the local anesthetic is prolonged. So by this, you're also preventing the side effects of local anesthesia by getting into the systemic circulation. Again, I tell you that this is a 3-mark question. What is the rationale for combining adrenaline with a local anesthetic? This again, when I'm taking the chapter on local anesthetics, I'm going to highlight it again. So this is one of the preparations which turns pink on exposure to air or even to light, so it needs to be protected. So uses, as I've already mentioned, the main use of adrenaline is its use in anaphylactic shock. At what concentration? I've already mentioned. Through what route? I've mentioned. Finally, at the end of today's class, if at all there is something which I want you all to remember, is obviously adrenaline uses. It comes as a 3-mark question, and the treatment of anaphylactic shock. Okay, yeah. And adrenaline, as I also mentioned, it is used in cardiac arrest, where you can be giving it through the IV route or directly into the intracardiac injection. In the form of intracardiac injection, you could be giving it. So the other use of adrenaline is to control local bleeding. If you are doing your ENT postings, you will face many cases, wherein your epistaxis is very common. This is nothing but bleeding through the nose. It's very common in hypertensives and also in young children who do a lot of nose picking. So in such a condition, what they usually do is the swabs, whatever they have, they or the packings, ENT, you tend to get your cotton packings. So that is dipped in adrenaline solution, and then you do a anterior nasal packing. Okay, so this is where you can use it as a vasoconstrictor. Because of its vasoconstrictor action, you can be using it for controlling the local bleeding in case of epistaxis. They are also used for other procedures like minor procedures, ENT procedures, and also for endoscopy. And they're also used for as a styptic agent. Styptic is nothing but that which prevents the um, loss of bleeding or loss of blood, or which stops bleeding by acting as a local hemostatic. So that such an agent is called as a styptic agent. Then it is also used for prolonging the local anesthetic action, which I've already mentioned, given as a combination with lignocaine. And the miscellaneous uses, as I've already spoken about it, for the treatment of bronchial asthma, especially in very young children with intense bronchospasm. You use it as an inhalational agent, and also for the treatment of insulin overdose. So this was a method which was used earlier, but now no, we use a glucose infusion, or at the most we give IV glucagon. Adrenaline, even though it has this hyperglycemic potential, the side effects are adrenaline are something what you have to look into. So for this reason, not a preferred method for treatment of insulin overdose. You can make a mention if you have a question on the uses of adrenaline, but it is out of use now for this particular therapeutic use. I hope I'm clear about the uses of adrenaline. So next, moving on to the other adrenergic drugs, noradrenaline. See, this drug, noradrenaline, even though it is one of the most commonest neurotransmitter found in your adrenergic neurons, its use therapeutically is not of much value because it is highly degradable by your COMT and MAO enzymes. So if at all you're using this clinically, the only indication happens to be as a last resort drug for inducing peripheral vasoconstriction um, in cases of severe hypotension. So, but you can't be using this alone, you have to be using it along with volume replacement. Okay, so this is a last resort drug. Next is your isoprenaline. Now, isoprenaline, if you remember the pharmacological action, so it has mainly beta action. It has no alpha action at all. So for that reason, you can't be using it for its peripheral vasoconstrictor effect, no alpha action at all. But yes, because of its cardiac stimulant properties, it could be used for treatment of bradycardia or heart block. This is the mechanism of action of isoprenaline is such that it tends to maintain the idioventricular rhythm. I hope you're all aware of this idioventricular rhythm. So it's trying to maintain the pace of the heart until you are going to, implant a pacemaker, which is going to override the idioventricular rhythm. So till then, you're going to maintain by using isoprenaline because of its beta 1 action. Then, because of its beta 2 action, also could be used in bronchial asthma. So as I mentioned, you have selective beta 2 agonists. So, those are being employed as the first line drugs in bronchial asthma. These have ancillary roles. The other use of isoprenaline happens to be your Stokes Adams syndrome. Then, dopamine. Now, again, dopamine is something what you all have to know because if at all you're working in your emergency room casualty department, this is one drug which is commonly employed whenever you get a patient with acute renal failure or myocardial infarction, cardiac arrest, and many other things. So dopamine, we start off on a dopamine drip, especially in cardiogenic shock. Okay, this is one of the drug which we start off. This is mainly because dopamine is a drug which tends to maintain the blood pressure, and also it improves your urine output. So, how is this action mediated? So, you will be surprised to know, just like your aspirin, dopamine is something which has a dose based action. So, I think in my previous class, I was mentioning to you about your baby aspirin or low dose aspirin. So, aspirin at different doses has different properties. Okay, so the at the lower dose or your baby aspirin, 75 to 300 or 325 milligrams, it acts as an antiplatelet agent. Between 1 to 2 grams or up to 3 grams, it acts as an analgesic drug. More than 4 grams, it is used as an anti-inflammatory drug. So, similar way, you have dopamine, which has a dose-dependent action. So, at low doses, that is at 2 to 5 micrograms per kg per minute, it specifically or selectively acts on the dopaminergic receptors which are present at your renal vasculature. So they specifically act over there and they cause vasodilatation. So this is going to improve your mesenteric and also renal blood flow. So this improves your urine output. At moderate doses of 5 to 10 micrograms per kg per minute, what happens? It selectively stimulates the beta 1 receptors and also your dopaminergic receptors. So, because of stimulation of your beta 1 receptors, they have a positive inotropic property with not significant chronotropic effect. So, cardiac output is increased with little or no change in the heart rate or the stroke volume. So, it's mainly because of your beta 1 action. The next is at the high doses, that is more than 10 micrograms per kg per minute. It is going to stimulate your alpha 1 receptors. So, these alpha 1 receptors are going to mediate your vasoconstriction and increase your heart rate and also increase the peripheral vascular resistance. So, dopamine, as I told you, it is one of the drugs which you are going to more frequently use it in terms of cardiogenic shock and septic shock also. In septic shock, it's your antibiotics which have a major role to play. Along with that, your volume replacement with dopamine to maintain the blood pressure. So these are the indications of dopamine. So again, dopamine is a very important drug. You need to know about dopamine. Um, uh, while we are talking about the chapter on shock, again, we'll be mentioning about dopamine and its uses. The next drug is dobutamine. Now, dobutamine, even though it is a derivative of dopamine, it has no activity on the D1 and the D2 receptors. Instead, it is one of the drugs which acts selectively at the beta receptors with a minimal alpha action. So it is a relatively selective beta 1 agonist. So once your beta 1 action comes into picture, so what do you expect? Increased force of contraction without an increase in the heart rate or blood pressure. So force of contraction and output. So which condition do you think it is going to be useful? You want the force of contraction and you want the cardiac output to increase. So which are the conditions? Especially in congestive heart failure. So specifically congestive heart failure following an myocardial infarction also, or a chronic congestive heart failure patient also, you're going to be using dobutamine. So remember dobutamine, even though a derivative of dopamine, doesn't have dopaminergic action. It is known, or the therapeutic significance of dobutamine lies in its activation of your beta 1 receptors. So this is very important. And the T half of this drug happens to be 2 minutes and it is usually given as an IV infusion. And when compared to your adrenaline, it is less arrhythmogenic. So I told you in the side effects and contraindications during my previous class also that adrenaline is one of the drugs which causes a lot of cardiovascular side effects and also CNS side effects, isn't it? So cardiovascular side effects in terms of enhanced blood pressure, palpitations, restlessness, tremors, anxiety. So all of these are your extension of pharmacological actions. And I've also discussed about the contraindications for the use of adrenaline. So you have to be very cautious while you are using adrenaline, especially in angina patients, because it increases the oxygen demand on the heart. So nothing like that seen with dobutamine. And also adrenaline is very arrhythmogenic. It tends to increase the idioventricular rhythms and also tends to activate the arrhythmogenic foci within your bundle of his and many other pieces. So highly arrhythmogenic. Adrenaline is highly arrhythmogenic, and especially with halothane anesthesia, you have to be very careful if you're using adrenaline. And also in thyrotoxicosis patients. So remember these side effects of adrenaline. So when compared to your adrenaline, dobutamine is something which has very less side effects. So next, the other use of dobutamine, something again I've used the same thing for one of the spotters for you all. So suppose you have to know the exercise potential of your heart. I think you have all heard about the treadmill test, isn't it? So that tells you if a person is, having any kind of an ischemic heart disease or something like that. Now, imagine you have a bilateral amputee or a unilateral amputee. How can you expect him to be running on the treadmill? That's not possible, isn't it? So, in such individuals, what do? You want to simulate the same findings, or you want to stimulate your heart by increasing the activity, exercise potential in the individual and seeing for the oxygen supply and demand ratio. So, for that reason, you've heard about dobutamine echo or the dobutamine stress test. So, because dobutamine is selectively acting on the beta 1 receptors present in the heart, it tends to increase the force of contraction without significantly affecting the heart rate or the blood pressure. So, what do you give? You give dobutamine, and it is used for dobutamine stress test or the stress echo because of its use as a cardiac stimulant. The other conditions where the cardiac stimulant property comes into use happens to be your congestive heart failure, chronic severe congestive heart failure also. So it could be either for a short-term management as a cardiogenic shock or a long-term management as a chronic cardiac failure. So short-term therapy, yeah, cardiac surgery, post MI, during MI. So in all these places, you could be using dobutamine. The next therapeutic use, as I've already mentioned, is the use of drugs as nasal congestants. So nasal decongestants. So these drugs, nasal decongestants, are primarily acting at the alpha 1 receptors which are present on the nasal mucosa. So what happens in terms of cold, when you have a severe cold, what happens? There is severe congestion of your nasal mucosa, and you have that difficulty to breathe, and you tend to do mouth breathing, isn't it? So, in such conditions, you are using topical alpha agonists, which act as vasoconstrictors, and they also cause blankening of the blood vessels. So, these alpha 1 agonists include phenylephrine, pseudoephedrine. So you have classification. So you have imidazolines also. These imidazolines, they are longer acting, and when compared to these which could also be used as vasoconstrictors anywhere else also, these have specific action on your nasal mucosa and specific nasal decongestants, mainly because they act at the alpha 2 receptors. So you have clonidine like drug, which I've already mentioned. They are alpha 2 receptors. They act at the alpha 2 receptors as agonists. So nafazolin, xylometazoline, oxymetazoline. So go back and see or Otrivin nasal drops and many other nasal decongestants, what they show on TV and all. They all contain your imidazolin class of nasal decongestants. So these imidazolins have a longer duration of action when compared to your pure alpha-1 agonists like phenylephrine and pseudoephedrine. And what happens is when you use it through the nasal route, there is some amount of systemic absorption occurring, isn't it? So in hypertensives, you have to be careful because these are again vasoconstrictors. They tend to cause an increase in the blood pressure. And because of their local vasoconstrictor action, they also cause stinging sensation. And if you have noticed, if whenever you have had a cold, the doctor would have prescribed you the nasal decongestants for a duration of 5 days. And they also advise not to be using it for more than 7 days. Have you wondered why? It's mainly because these nasal decongestants, they also tend to harm your nasal mucosa by causing blanching. Obviously the blood supply is going to be reduced because of vasoconstriction, and the epithelial damage also tends to occur. So this in turn may lead to degeneration of the epithelium, and when you give it for a longer time, it tends to cause a rebound rebound condition. So this condition is called as rhinitis medicamentosa. Okay, medicament means your medicine, some kind of a rhinitis which is occurring because of overuse or abuse of nasal decongestants. So as I mentioned, you have to be very cautious in patients with hypertension, and also people who are taking MAO inhibitors. I'm not sure if I told you about something called as the cheese reaction last time. Yeah, I mentioned about the cheese reaction. So whenever you're using your indirectly acting drugs like tyramine, amphetamine, and all, you have to be very careful for those which contain, food substances which contain tyramine along with MAO inhibitors. So this is because it can lead to hypertensive crisis, causing something called as the cheese reaction. Cheese contains a lot of tyramine. Okay, yeah. The next thing, the next drugs are your phenylephrine. Now, phenylephrine is a selective alpha 1 agonist. So, this is used as a nasal decongestant, which I've already discussed previously, and used as a vasopressor. So, vasopressor agents, they're mainly used in conditions which cause severe hypotension. So, this hypotension it is usually seen in all conditions of shock, and you're all aware there are various types of shock like hemorrhagic shock, a hypovolemic shock, then cardiogenic shock, septic shock, and many other things. So it's basically used in shock which results from any trauma to your spinal cord, autonomic nervous system failure. So because of that, you have spinal shock. So in that conditions, vasopressors are very much used, especially phenylephrine. The other use of phenylephrine happens to be it's used as a midriatic. Okay, if you remember, alpha 1 receptors are present on the radial muscles of the iris, and by using alpha 1 agonists like phenylephrine, you're bringing about mydriasis. And the thing what differentiates it from your atropine like drugs is that these drugs do not cause cycloplegia or loss of accommodation, mainly because they are not acting at the receptors present on your ciliary muscles of the eye, which brings about accommodation. And alpha 1 receptors are also present on the epithelium, which helps in secretion of aqueous humor. So it reduces the intraocular tension. Then pseudoephedrine. Pseudoephedrine is another drug which is again used as a vasoconstrictor. Again, its action on the mucus and the skin vasculature is something what you have to know, and it has no beta 2 action. So mainly pseudoephedrine is used for upper respiratory tract decongestant use, and also for allergic rhinitis and eustachian catarrh. Pseudoephedrine can be used orally, unlike your adrenaline, which has to be given through the parenteral route. So these both the drugs can be used in the topical as well as oral form. So any drug which is given orally, please remember they are not highly metabolized by either MAO or COMT. So such drugs you can be given orally. Okay, now you have a 65-year-old gentleman, a male, So he has complaints, if you see the history over here, he has complaints of visual difficulty, halos around lights, and frontal headache, chronic frontal headache. So all of these signs are pointing towards glaucoma. Okay, and the specific diagnosis after applanation tonometry happens to be that his intraocular tension is raised. So anything about 21 millimeters of mercury, you can clearly say that it's a case of glaucoma. So in this individual, he requires a fundoscopy. Okay, so which mydriatic you're going to use and why? So think about it. What do you think? Which mydriatic you want to use? So obviously something which reduces the intraocular tension, and this is just fundoscopy. You don't have to do refraction error testing. So you need not have to, paralyze your ciliary muscles. So for this reason, you use a active mydriatic. So active mydriatic, we have already studied about phenylephrine. So you know that such active mydriatics are helpful in elderly individuals. Again, elderly individuals, in them atropine is usually contraindicated, mainly because of BPH. Okay, benign prostatic hypertrophy. Atropine tends to, reduce the urine flow by altering the detrusor and the trigone dynamics. Okay, so this is what happens when you use atropine. Contraindications of atropine. I know I'm deviating, but as I've already told you, both your autonomic nervous system and your your sympathetic and your parasympathetic nervous system, they're always at loggerheads. So the best way to study the entire thing is to compare and contrast things. Okay, so that is why atropine, I'm just bringing in atropine over here. Atropine is contraindicated in acute congestive glaucoma and also in people with shallow eyes or angle closure type of narrow angles. So in such individuals it is contraindicated, and also in elderly males with benign prostatic hypertrophy. Okay, the other vasopressor agents we have studied about phenylephrine, isn't it? So that's alpha 1 selective. The other one happens to be methoxamine, very similar to phenylephrine, not much of a difference. So you use them as vasopressors, as I've already mentioned, in hypotensive states. Then the non-selective ones include norepinephrine, dopamine. I've mentioned about them, but you have to be careful about the alpha 1 action along with the dose dependent action of dopamine. You have to look into it. Then ephedrine and mephedramine. Now ephedrine we are going to discuss about it. Mephedramine is the other drug which is used as a vasopressor agent. So all of these are your alpha 1 alpha agonists. Now ephedrine, the moment you come across ephedrine, you have to understand that ephedrine is one of the drug which is known to cause tachyphylaxis. I'm sure you've studied this in your practicals during your classes on graphs also. So tachyphylaxis is nothing but when you repeat a drug over and over a period of time, the response is going to be plateaued. The main reason is because of the degradation of the neurotransmitter, because production is not matching the release of it. And also the receptors are going to develop tolerance. For example, I usually give this example. Suppose you're hearing or listening to my class for a long period of time over and over, the entire week I've been taking classes, obviously you start losing interest, isn't it? Because your receptors have become saturated. Similarly with drug also, like ephedrine, tyramine, amphetamine, basically. So when you give the drug over and over or again for a long duration of time, there is going to be down regulation of the receptors and desensitization of the receptors, and also degradation of the neurotransmitters. So this is the mechanism of tachyphylaxis. So this again is going to be explained to you in detail in your practical classes also. So this ephedrine is derived from it's an alkaloid. So alkaloids are nothing but plant derivatives with nitrogen bases, isn't it? So alkaloid, ephedra vulgaris, mixed action drug. So what do you mean by mixed action? It directly acts on the receptors postsynaptically, but it also is taken up by the norepinephrine transporter and it displaces norepinephrine from the synaptic vesicle. So this is something called as a mixed acting sympathomimetic drug. So the uses of ephedrine include it's a CNS stimulant, has a bronchodilator action also, can be given orally, resistant drug to the metabolizing enzymes. 3 to 6 hours, not preferred mainly for its hypotensive action. I mean, not generally preferred because of its side effects. So if at all you're preferring, it could be used as a hypotensive and also as a nasal decongestant. But again, from the examination point of view, they give it as a 3-mark question. So please remember to study about ephedrine. The other selective beta 2 agonists are their use in bronchodilators and also as uterine relaxants. So this is mainly, these are the places where your beta 2 receptors are present. So which are the bronchodilators? You have salbutamol, terbutaline, salmeterol, and formoterol. So these are the longer acting ones, salmeterol and formoterol, when compared to salbutamol and terbutaline. Uterine relaxants, you have an entire chapter on drugs acting on uterus. So there again, we are going to be discussing about the uterine relaxants. So this includes again salbutamol, salmeterol, ritodrine, and isoxaprine. So where are uterine relaxants used? Especially in preterm labor. So there you would be using uterine relaxants. So the other use happens to be in familial hyperkalemic paralysis, because in pharmacological actions I've told you how your adrenaline-like drugs are going to affect the potassium concentration. Okay, so for that reason, they are used in familial hyperkalemic paralysis. Okay, the other therapeutic classification includes your CNS stimulants. CNS stimulants, which include amphetamine. So if you remember, amphetamine again is a mixed acting drug, isn't it? So amphetamine, it's going to be taken up by the norepinephrine transporter, and it is going to replace noradrenaline from the synaptic vesicle. So this noradrenaline is going to stay for a longer duration within the synaptic cleft, and it's going to act on the postsynaptic receptors. So these are your psychostimulants. Now, amphetamine is one of the drug which is used as a drug of abuse. It's a very common drug, mainly used by youngsters. Um, Very commonly, again, I'm telling you this, very commonly used in hostels. You know, what does this drug do? Amphetamine. It is going to enhance your energy levels. You're going to be alert. You're going to be more receptive for learning, and you don't have that fatigability. You don't feel fatigue at all. You're completely charged up. So what do people do? They tend to take this drug during examination time so that your sleep is ward off. You don't sleep and you're very active. But one of the side effect of amphetamine happens to be that once the drug starts waning off, you know, there is going to be a lot of fatigability which is going to set in. So the use of such drugs during exams or one day before exam, it needs to be discouraged. Okay, so this is also known to enhance your athletic performance. Sleep is not anywhere coming near you, mainly because of your reticular activating system activation, enhances your respiratory center, and also has antiemetic effects. So this is one of the drugs which has a very high abuse potential, and since it is going to reduce your appetite, um, the loss of buccal pad of fat over a period of time is one of the telltale signs of amphetamine abuse, drug abuse. So yeah, this is again, amphetamine is again one of the drug which exhibits tachyphylaxis. So amphetamine, you're again going to study about amphetamine during your CNS stimulant classes also. So you have amphetamine like group of drugs like modafinil, then methylphenidate. So everything is going to modulate your noradrenergic levels. So they are used mainly for attention deficit hyperkinetic disorder and for improving memory. So CNS stimulants. This is these drugs are used in such cases. Next is your tyramine. So tyramine again, indirectly acting drug. I told you we talked about this cheese reaction with MAO inhibitors. You have to be very careful when you're taking food substances which contain tyramine. So that includes wine, red wine, cheese, then fish. So all of these have to be avoided whenever you're taking MAO inhibitors. If not, that causes cheese reaction. It's nothing but hypertensive crisis because of enhanced noradrenergic levels. And noradrenaline, it's a very good vasopressor. It's used for in enhancing the blood pressure. So it causes hypertensive crisis. The next use is anorectic agents. So these group of drugs, norepinephrine, noradrenergic group of drugs, they tend to um, act on your satiety center and you don't feel hungry. So these are appetite suppressants. So because of this reason, they were used to reduce appetite and they were used as anti-obesity medications. So those drugs which release only norepinephrine included phenylpropanolamine and phentermine. Those which would inhibit the reuptake happens to be your drugs like amphetamine, sibutramine, and the racemic isomer of sibutramine. Now, there are other drugs which modulate your 5-HT levels. So, these are your serotonergic agents like fenfluramine, dexfenfluramine. But the main drawback of all these drugs was that side effects were um, very, very glaring. It led to deaths because of stroke. Okay, very severe adverse effects. For this reason, all of these drugs are not anymore US FDA approved. But still, you could be writing these names because I told you once anti-obesity agents came as a 3-mark question. So at least if you write these names as well and good, you will be getting marks. So if at all pure anti-obesity drugs you want to list, then it includes leptin, orlistat, rimonabant, olestra, and mirabegron. So these are some of the pure anti-obesity agents. Now, I want to summarize what all we have discussed along with the individual drugs depending on the pharmacological actions. So you have vascular uses and non-vascular uses. So vascular uses includes use in hypotensive states, especially in shock, especially neurogenic shock. Okay. And then you're combining adrenaline with local anesthetic. So you have all possible local anesthetic actions. So it could be used in spinal anesthesia, could be used for field block, nerve block, and many other things. Again, when we talk about local anesthetics, we are going to talk about this, and it's used as a local hemostatic agent, as in case of epistaxis or where you're doing endoscopies. Okay, over there you could be using as local hemostatic agents. These imidazolin and the non-imidazolin drugs, they are used as nasal decongestants. Hypotensive states, as I mentioned, in shock, spinal anesthesia, and also sometimes drug-induced hypotension. Continuing with the therapeutic uses, you have your drugs which are used during cardiac arrest and also for AV blocks, especially your isoprenaline. I told you, other than your isoprenaline, the other drug of choice happens to be atropine. Okay, please remember that. Then it's also used for congestive heart failure, especially your dopamine and dopamine is something which come handy in CHF. Next is your asthma and COPD. You will be seeing in your postings how a combination of salbutamol with ipratropium bromide has been used for the treatment of asthma and COPD. Then is your allergic disorders. Anaphylactic shock, most commonly used is your adrenaline along with a shot of hydrocortisone hemisuccinate. Then you have uterine relaxants. So uterine relaxants, as in case of preterm labor, we use ritodrin, isoxaspirin, which are your beta 2 agonists. Then the other CNS therapeutic uses, mainly they are used as CNS stimulants. CNS stimulants, so that is in case of narcolepsy. Narcolepsy is nothing but sleep which occur in fits. The person is normal, but he falls asleep. Um, I mean, even in what do you say in unusual circumstances. So he's in a meeting, sitting in a meeting, and all of a sudden he falls down asleep. Okay, don't equate this to your pharmacology classes where most of you tend to fall asleep. Okay, so narcolepsy is something like that. And then attention deficit hyperkinetic disorder. I told you your amphetamine-like drugs, methylphenidate, they are used. Next, appetite suppressants. We have discussed about it, how most of your noradrenergic drugs act as anorectic agents. And then some of them have your anti-epileptic use also for treatment of Parkinsonism. For bladder control, mirabegron is one of the drug which is used for bladder control. So nocturnal enuresis along with the desimipramine. These are some of the drugs which are used. Insulin hypoglycemia, obsolete use again. And as mydriatics, phenylephrine is one of the drug which is being used. So I come to the end of the chapter. So we have therapeutic classification. Questions which come very frequently from this chapter are the therapeutic classification of sympathomimetics, which comes as a 5-mark question. Adrenaline, adrenaline uses very frequently asked. Treatment of anaphylactic shock is again frequently asked. Then you have the individual drugs. Vasomotor reversal of tail, I told you it comes in your practicals also. Tree markers like nasal decongestants, anti-obesity drugs, and vasopressors is something what you have to look into. So with this, I've completed the adrenergic drugs. The next is your antagonists. Okay, so thank you so much for your patient listening.